The broadcast is now starting. All attendees are in listen-only mode.
Hello, this is Catherine Poole, President and Founder of the Melanoma International Foundation. Today we will discuss many of the new discoveries that were presented at ASCO last June and the promising clinical trials that were connected to these discoveries. With us today is Dr. Richard Joseph. He's a clinical instructor of medicine at the Mayo Clinic in Florida. He completed his clinical fellowship at MD Anderson. As a junior faculty member at Mayo, Dr. Joseph's clinical focus is on treating patients with melanoma, and he's particularly interested in the combination of targeted and immune therapies. At the end of the presentation, we will discuss your questions, so please stay tuned. And now I'd like you to join us in welcoming Dr. Richard Joseph.
Okay. Thank you, Catherine, for that nice introduction, and thanks for the Melanoma International Foundation for having me. I hope this will be helpful. Catherine asked me to do this talk, and it was basically an update on ASCO, on the major clinical trials that we thought were important for patients to know about, and my perspective on those trials, as well as how we are looking at these trials, how are they going to move forward, and how patients should perhaps think about them when they're being treated today. All right, so let's see here. There it goes. So overall, I'm going to talk about two classes of therapies which melanoma could fall into: targeted agents as well as the immune therapies. In the targeted category, we're going to talk about the updates on the BRAF inhibitors, MEK inhibitors, as well as the combination of the BRAF-MEK combination. And then for the immune agents, we'll be giving you just another background. We have to talk about ipilimumab, although not much new there, and as well as the PD-1 story. So starting off with BRAF and melanoma, this is something that was discovered around 2002. Originally, it was thought to be as high as 60% BRAF mutations in patients, and we're finding that it's probably a little bit lower than that, actually. And this is a study presented by Georgina Long in 2011, took all patients that came in treated with an intention to be treated on a BRAF inhibitor, and they found that actually 46% of the patients did have a BRAF mutation. However, of those patients with a BRAF mutation, only 34% had a V600E. And that's important, as you know, that the current drugs right now are only improved for V600E. However, 7% of melanoma patients will have a V600K. The activity of the BRAF inhibitors in V600K is not well established. However, there is some evidence of activity. This is important for patients to know that I think there's their BRAF status, not only the E but the K, if they can, because I do think that's going to help them get into trials. Whereas if they just know they're V600E negative, that doesn't necessarily mean that they are BRAF wild type. They could have a K mutation, and I think that patients need to be aware of that. So this is I'm going to present the update of the Vemurafenib trial, the BRIM3 trial, presented by Dr. Chapman, and this was originally presented in 2011 at the ASCO plenary session, and I'm going to talk about the updates. But just to remind everybody, this was a randomized phase 3 study of patients that were previously untreated. It was comparing Vemurafenib to DTIC or dacarbazine, 675 patients, and all had to have V600E, again, not K. So this is the update from presented in 2012. So the first thing that I want to stress is that patients were allowed crossover eventually on this study. The original study was not allowed, but once they had reached their endpoints and they knew that this drug was going to get approved and the FDA was satisfied, they did allow crossover. So, but these slides are the curves censored at the time of crossover. So the first one is the progression-free survival on top, and you can see that Vemurafenib added about 6.7 months compared to dacarbazine. Very impressive. The overall survival was, again, censored at cutoff, but it was 13.6 months versus 9. Where was the dacarbazine was 9.5 months. So that kind of gives us a better idea of the actual advantage that Vemurafenib gives over traditional chemotherapy around 4 or 5 months or something like that. The survival, again, was much better at 1 year. And this was with 12.5 months of median follow-up. Okay, this is another, I think, important point that Dr. Chapman brought up, and this is what's called a forest plot, which shows the benefit of Vemurafenib versus dacarbazine depending on the characteristic of the patient at the time of enrollment. So anything on the left side of that red line means that the patient's benefited more for Vemurafenib, and if it crosses over the red line, the benefit for Vemurafenib was wasn't statistically significant, let's put it that way. So the thing I want to draw your eye to is the disease stage here. So melanoma patients, as you know, are divided into stage 3 or 4, 4A, B, and C. And you can see here, right here, is that the 4C patients are clearly deriving the most benefit compared to chemotherapy. And why do I bring this up? Because I unfortunately see some patients that come to my clinic that have maybe low volume disease, 4B, 4A, and they come in already treated on a BRAF inhibitor. And while I think that's okay, I do think it already starts the clock of Vemurafenib resistance. And I'm not sure if if starting the clock at such an early time point is a good idea. However, this is still just an opinion. We don't have any trials to suggest that when to start the clock is the best time to do it. But I think this data, as well as our clinical intuition, is helping us guide of when to start therapies, and we would prefer to start a Vemurafenib or a targeted agent when we really need it, which is in these the M1C patients, stage 4C. The next big breakthrough that was talked about at ASCO is the second BRAF inhibitor called Dabrafenib. That's the GSK GlaxoSmithKline's compound. This study was very similar to the Vemurafenib study. It was another randomized phase 3, untreated patients, slightly smaller in number, and it required V600E, not K. So this is on the top is the waterfall response rate, so showing that the vast majority of patients who got this drug, just like Vemurafenib, had an excellent response. Close to 92% of them are below the line, or only 8% of the patients actually had some disease resistance at the primary at the time of initiation. The bottom curve is the progression-free survival, and you see here at 6.1 months, slightly smaller than the Vemurafenib phase 3, which was 6.7. Does that mean this drug is less effective? No, it does not. These are two different populations of patients. I think you could safely say that these drugs are probably, for the most part, pretty equivalent. They don't have overall survival for this drug yet because it's so new. Okay. So the summary for BRAF, this is actually a patient that I treated as a fellow at MD Anderson a couple of years ago, a 28-year-old female who basically had gone through several lines of therapy by the time we had seen her, and this was right when the Vemurafenib trial, the phase 1, had come out. And this is, on the left-hand side is her baseline imaging, and the other, you could see the black spots are all where the melanoma is, and the black spots don't also emphasize how poorly she was doing clinically. She was not doing great, in a wheelchair, actually not able to walk very well, and in a lot of pain. What was striking, obviously, is that after 2 weeks of treatment, she has essentially a PET complete response, but also her performance status was greatly improved, able to literally run down the hall. Unfortunately, 6 months later, we saw that she developed resistant disease, and it came back in lots of places, and just as aggressive, or even maybe more aggressive than it was before treatment. And unfortunately, she passed away a month after becoming resistant. I bring this up because this is, again, trying to emphasize the point that the BRAF inhibitors are great drugs. as clinicians, we are so excited about these. However, we know that they are only providing a limited amount of benefit. And because it's a limited amount of benefit, we need to decide when to best use these drugs. And if we can, and I'll get to this at the end on a treatment algorithm that I've made for how I treat patients, I prefer to use it when we absolutely need it. In this patient's case, I think we did absolutely need it. She was going to pass away if she didn't get therapy at the beginning, but this is just something to keep in mind. Okay, next. So this is the pros and cons of BRAF inhibition. The response rate is excellent. The drug is well tolerated. These are great things. The bad thing is, yes, there is a short duration of response. On average, it's about 6 months is what I usually tell patients. Of course, there are patients that last a lot longer, but there's patients that last a lot shorter as well. There are multiple escape mechanisms. That's another big problem that's going to keep us busy for a long time. In the last 2 years, there's been Nature paper after Nature paper publishing on different mechanisms for BRAF resistance. So unfortunately, every patient that becomes resistant, we're going to have to figure out what's going on in their tumors. We can't do a one-size-fits-all approach like we did when we treated them with a Vemurafenib and a BRAF inhibitor. We're going to have to figure out why their tumor became resistant, which is going to be challenging, but I think we'll be up for the challenge. So then the other thing is the V600E and not K. It's not approved for K. With that being said, I have been able to do it. We're writing insurance companies and things like that to get it approved, but this is just another, I just want to keep emphasizing that point. Next. Okay, so the next trial that was presented was, I thought was relevant, was the MEK inhibitor, and this is another phase 3 trial presented by Keith Flaherty at ASCO, and this was another randomized phase 3 trial. These were, again, previously untreated patients, and this was a MEK inhibitor versus the chemotherapy of choice by the treating physician, and it was randomized in a 2-to-1 ratio. This trial did allow V600K, which was I thought laudable and it's going to help us provide with more information. And the other laudable thing was that they did allow crossover. So as soon as the patients did not do well on chemotherapy, they were allowed to get the MEK inhibitor. Okay, this is a little sticky. All right. So the first thing that you don't see on this slide is actually there's not a waterfall plot like you see in the BRAF inhibitors. The lack of the waterfall plot does tell you that the response rate is not as brilliant as it is in the BRAF inhibitors. So the response rate, as you can see here, as I listed, is 22% with a disease control rate. That includes people with stable disease at 78%. And if you do respond, the duration of response is about 5.5 months. The progression-free survival for the MEK inhibitor was about 4.8 months, which again is less than that we see with the BRAF inhibitors, but slightly less. Again, it's cross-trial comparison, so it's hard to say if this drug is truly less effective than the BRAF inhibitors in terms of progression-free survival, but I think most people think that it probably is. Again, the survival they did have at 6 months, it was improved, 81% versus 67%. It probably would have been a lot higher had they not allowed crossover. So the fact that they were able to get overall survival with crossover was very, very nice. So then the next trial that was presented by Jeff Weber is this: if BRAF inhibition is good and MEK inhibition is good, what about the combination? And this is the results of the phase 1 trial of combining the BRAF and MEK inhibitor, both GSK combos, Dabrafenib and Trametinib. 77 patients. These are people who did not receive prior BRAF inhibitors, and again, they weren't allowed V600E and the K. Okay. Oh man. All right. So there is we have a waterfall plot. That's a good thing. That means that a lot of people responded. And, the resist where the dotted line is about 56%, and then the disease control is 92. You can see on the top curve too that the Ks are in there. So the Ks did well too. So that's a good news. That's good news for the 7% that are K. The progression-free survival. What's interesting about this is that this has both all dose levels, and then the highest dose level is the blue line. because this was a phase 1 trial. They were testing different doses, but at the highest dose level, the progression-free survival is 10.8 months, which is, perhaps going to be a lot higher than the BRAF alone or MEK alone. So that is really promising, and one of the reasons why that I would highly consider treating any patient with a BRAF mutation with this combination. That would be something that, because of this data, is pretty persuasive. My only concern with this data is when patients do become resistant to this combo, what are we going to do then? That's my only concern. And so there are some thoughts of, well, maybe we should be treating patients with the BRAF inhibitor when they become resistant, then try BRAF MEK and see if we can, milk everything out of BRAF that we can. And I don't think anybody has the right answer to that. So now switching gears to immune checkpoint blockade. This is a slide bar from Tony Rebus in the New England Journal. On the left-hand side is the pathway by which early T cells are activated, and that's one of the most early signals that inhibits or is the break of the T cell is called CTLA-4, and ipilimumab inhibits CTLA-4, and that's the drug that we've known about for a little while. Later on in T cell activation, another break occurs, and that's called PD-1, and that PD-1 it binds to the ligand PD-L1, which can be present both on tumors as well as our normal immune system, and this happens later. So now we have therapies that can inhibit both early and late T cell activation. So just to review here, the only study that I'm bringing up here from ASCO 2012 was this ipilimumab plus Timidar. This study was a phase 2 study by one of my old colleagues at MD Anderson, Sapna Patel. This I thought was kind of interesting and worth talking about rather than talking about the large phase 3s that were presented several years ago. So this is a phase 2 study. These are people that were untreated. And the treatment basically was ipilimumab with 10 milligrams per kilogram, high dose ipi, and Timidar every days 1 through 4 through every cycle. And the results of this was kind of interesting. At this point, the median overall survival was not reached. And the curve on the top, she shows that if you had bone metastases, the patients with bone metastases did poorer than the people without bone metastases. The other thing that segregated survival was if the patient had a performance status of 0, meaning they were unlimited by their cancer, they did better than people who weren't limited by their cancer. The other thing that is interesting, I think, is the response rate. The complete response was 15%, and the partial response is 12.5%, for giving you a total response of 27.5%. So this is almost double, it's over double, almost triple the response rate of single-agent ipilimumab, at least at the 3 milligram dose. And what is interesting is that the addition of chemotherapy, Timidar, could improve the response rates, because the response rates of the ipilimumab and dacarbazine, which was presented last year by Dr. Walchuk, did not really increase the response rate to the degree that this did. And the question is, why? And perhaps some of the clue is that Timidar it does not affect the liver as much as dacarbazine, and therefore maybe the doses of chemo were able to be tolerated higher than dacarbazine. And this might be a very interesting strategy moving forward. And also the PFS at 6 months, it was 45%, which is significantly higher than prior studies with ipilimumab and Timidar, ipilimumab and dacarbazine. All right. So the pros of ipilimumab. So overall, I think this is another game-changing drug, but I wouldn't call it a home run. The improvement in overall survival depends on what you're comparing it to, but I would say most people would say on average 2 to 4 months. However, there's also a 10% improvement in the long-term overall survival. So for every patient, if it doesn't get ipilimumab versus that does, has about a 10% at each year following treatment. Also, the toxicities are very manageable, I think, although worse than maybe some of the target agents, but certainly manageable. The cons, the response rate's low, at least as it's currently given, 10 to 15% response rates. And the other problem is that the responses occur at a very slow rate, which a lot of patients don't have the time for this drug to start working. So moving over to the other side is we're going to start talking about PD-1 and PD-L1. So the first study is the PD-1. This was presented at ASCO, and this is a phase 1 study, multiple centers. And so phase 1 meaning multiple doses of PD-1 were chosen, anti-PD-1, 296 patients. I'm just going to focus on the 94 patients that were treated with melanoma. So this is the response rate for patients with melanoma, and it was overall 28% of the people who had melanoma responded. Now the dose perhaps matters. 17% of the lower dose and up to 41% of the high dose responded. This next curve shows instead of water, so the waterfall plot is the plot of choice for a targeted drug where you see a really nice decrease in tumor size. This is called I think people are calling it a spider plot, is I think the plot of choice, because this time it emphasizes not only size but also time. So on the x-axis down here, we can see that these are the weeks after treatment, and then on the y-axis here is the size of the tumor from the time of treatment. And these are the 27 patients treated at 1 milligram per kilogram. And what you notice is that two things: of the people that were responding, or at least staying stable, they were staying stable for a very long time. We're up to here. There's 100 weeks, so that's 2 years. So that's pretty impressive. If it works and stabilizes patients, it works for a long time. The other thing that was interesting is that it doesn't work right away. Look at that. I mean, this patient was stable, but then starts coming down at 20 weeks, and this is a lot longer. It takes longer for it to respond, but when it does respond, it looks like it works for a while. See here. Okay. Now this, I think, is probably one of the more important parts of the study. This is also in the paper. This shows that we might actually have a biomarker for patients who are going to respond to PD-1. So the investigators were able to have tissue on the patients. This was of the 42 patients that they had tissue on. They looked at this, and the patients who had no PD-L1 on their tumor, none of them responded, 0 out of 17. Whereas if they did have PD-L1, there was a 9 out of 25 patients that responded. So whether this is going to, again, hold up, I think is going to be the subject of future studies, but this will be interesting, a new way that we finally have a biomarker for immune therapies. Okay. PD-L1, so this was the sister or study of the PD-1 study, occurred around the same time. 207 patients, phase 1, multiple doses. And again, I'm just going to focus on the 55 with melanoma. So the response rate here was about 17% overall. And again, it varied by the dose level, 0 to 29%. In terms of the spider plot, again, this is the 17 patients treated at 3 milligrams per kilogram. And the same message, I think, it can be seen here, is that the duration of responses were very long, as you can see here. And then, there obviously were patients that didn't respond. It's hard to say. I don't think anybody knows which one of these drugs is better, PD-1 or PD-L1, and that'll probably be the subject of future studies. So the other thing that we should talk about is the safety of both of these drugs. I would say that they are looking to be very safe compared to traditional chemotherapies, and perhaps even compared to ipilimumab. They seem to be better tolerated. Overall, a very small amount of people with grade 3 and 4 events, 9 to 15%, depending on PD-1 or PD-L1. The side effects are similar to IPI, but not quite the same. You can get rash and hypothyroid, but not a lot of the diarrhea that's seen in IPI. However, pneumonitis or inflammation of the lungs seems to be more common in PD-1 rather than in ipilimumab. Okay, summary. So the efficacy, defined by response rate, looks like it's about 35% of patients are responding. That number might be higher or lower based on the tumor staining by PD-L1. We'll have to see in the future. I think this is, needs to be commented that this is much higher than the response rate of ipilimumab. And the side effects seem a little bit less. So if I had a choice of one of these drugs, I would probably want a PD-1 or PD-L1. But the question that remains unknown, if you don't respond to one, will you respond to the other, meaning IPI or PD-1? I don't think that's answered yet. The safety is good. The biomarker, having a biomarker, potential biomarkers is great. So there's many trials right now undergoing with PD-1 in both single agents and combinations. I'll list those in general below. So then I just have a quick slide about my treatment algorithm, just in case anybody is wondering. And this is not driven by any clinical studies yet, because we don't have the studies to do this yet, although I think we will. But if a patient walks in the door and I see them for the first time and they're untreated, the first thing I do want to know is their BRAF status, and we send that off. And then I divide them into, do they have a BRAF mutation or do they not? And then the second most important thing is the disease burden. Is this patient someone that is walking in with a tremendous amount of disease and severely limited by their disease? Then I try to, if they're BRAF mutant, I do think about a BRAF inhibitor. And if I have a choice, I would put them on a BRAF inhibitor in the MEK combination. There is going to be a phase 3 study starting on that soon. It will compare BRAF MEK versus BRAF alone. If the patient is BRAF mutant or wild type and they have a low burden of disease, I certainly favor immunotherapy at this point. This is when I consider IL-2, still, even in some patients that are the select patients, ipilimumab certainly, and then the PD-1 trials as well. These are great candidates. If their disease is high in your wild type, now this is, I think, the most important time for clinical trial. Now, I want to say, honestly, all of these I would prefer a clinical trial, but I recognize that's not, pragmatic or practical in the rest in the whole world. So I don't want to offend anybody by saying that everybody should go on a clinical trial. If you don't live near a site, that's not available. But I would say I would like to do that for all of my patients. So talking about clinical trials, the ones that I would be very interested in and going on and think are going to be interesting. So if you're BRAF mutant, I think the BRAF MEK combination is extremely promising based on the phase 1 data. I still, like I've said before, I don't know if that's going to be better than going BRAF followed by BRAF MEK or just starting with BRAF MEK. I don't know the answer to that, and nobody does. Another target that looks like it might be interesting that might be coming around is MET and BRAF. Immune therapy, again, anti-PD-1, PD-L1, adoptive cell therapy, I think are interesting trials. MD Anderson, Moffitt, NIH have those. The combination trials is something that I'm very, very interested in, and I think this makes a whole lot of sense of how are we going to combine our targeted agents with immune agents and try to get the benefit of both. So the high response rate of the targeted agents with the durable response of the immune agents. I think those trials are already underway. BRAF-IPI is at least. This BRAF PD-1 is, I know, in the works, although I don't know if it has opened yet. The other sequence-based trials, for instance, what should we do first for some of these patients? Should they get BRAF followed by IPI or vice versa? And the other question that we're trying to find out, is there the right time to add IPI? Maybe we don't want to add IPI at the time that a patient progresses on a BRAF inhibitor, but maybe there's a sweet spot somewhere along the line that the patients could benefit from. Another trial that we're going to be opening and other centers is a genomics-based trial through the Stand Up to Cancer grant, where it's going to be all patients are going to have their whole genome sequenced as well as the transcriptome. The transcriptome is their RNA, and we're going to be, these are patients that are BRAF wild type, so we're only focusing on the ones that we don't have a known targeted mutation and hope to identify novel mutations where we can direct them towards therapy. There's some surgical trials that I think are interesting. We still don't really know if some people have an isolated metastatic site or maybe two sites. Should we remove the tumors? I think we do know that the cure rate is lower, is probably still low by removing isolated metastatic disease. However, it might it still might improve the overall survival even if it doesn't cure. So I think those are questions that need to be answered. And then I think radiation combined with immune therapy, there's been some publications on this that I think is very interesting. I think that the radiation on a tumor can provide perhaps an in vivo vaccine, and adding the immune therapy at that point could potentially be beneficial. And I believe that was my last slide. So I'll turn it over to Catherine and happy to answer some questions.
Wonderful. Thank you so much, Rich. Very powerful and provoked a lot of questions in my head. I'm going to ask you some questions from patients and from myself for patients. And my first question to you is, and this has puzzled me for some time, is I understand the idea that if we start a therapy too soon, that, you know, the resistance will start sooner, you know, for the BRAF you mentioned. But why not in high-risk stage 3 patients can we not start, you know, at least the immunotherapies so that, you know, possibly, you know, creating a better scenario than waiting for it to become stage 4? I mean, we really have nothing to offer our stage 3 patients that are very high risk. You know, they have positive nodes and they have very deep, you know, melanomas.
Well, that is being addressed. I didn't put adjuvant on here, and we're part of a large nationwide trial, ECOG 1609, that is comparing ipilimumab to interferon, and it's a 3-arm study of the low-dose IPI, high-dose IPI, and then interferon is the 3rd arm, and we have several patients on that. And I absolutely agree with you that we need to do. I think this is the best, in my opinion, adjuvant study out there. You know, I think we do need to show that ipilimumab will be beneficial in the adjuvant setting before just, you know, non-selectively putting patients on that. So I know that's going to take a little time to get the results of an adjuvant study. Always takes longer because the endpoints are longer. But in principle, and if it were me and a family member, absolutely, I would want them to be on ipilimumab or PD-1 or if we could. The only way to do it, though, right now is through a clinical trial.
Now, is there an issue in those trials? I've heard from patients that, you know, they're told up front if they're on interferon or on Yervoy, and many drop out if they're given the interferon.
Yeah, you know, I think every single one of my patients asks me that question, and I think the ethical thing to do is to say, if you're going to plan on dropping out immediately upon hearing that news, then you should not sign up for the trial. But I think it's also ethical for them to, if they go on the interferon arm, and at least give it a try, and if it's just too miserable for them, and oftentimes it is, then they don't do it, and then their data is at least collected a part of the clinical trial, and it will help at least hit all the endpoints, because there's going to be, you know, 1,500 patients, 500 on each arm, and, you know, the quicker we can get all the people on the interferon arm too, you know, the bad luck, then that's good. It will still, those patients will still, I believe I'm speaking correctly, will be counted as a part of the study, because we'll know their follow-up as well as their overall survival. And as we all know, interferon doesn't improve overall survival compared to doing nothing. It does improve the relapse-free survival, that's for sure, but overall survival it doesn't. So I think it's not really muddying the study if they drop out too soon.
Okay. Yeah, I mean, I was just going to say, I mean, there was an ASCO statement that said that interferon did not prolong overall survival. So many folks are, taking that to heart, and they're not going to go on it.
Yeah.
It's not quite the gold
I mean,
standard.
the first study showed improved survival, and every single study since then has only showed relapse-free survival.
Right.
If it were me, I mean, now there's some evidence that perhaps patients with ulcerated melanomas are the only ones deriving benefit from interferon. This is still retrospective and not prospective. I don't think anyone can make that statement. So if it were me and I had an ulcerated melanoma and I was stage 3, and I went on this study, as a young guy with a young family, I'm probably still going to do the interferon, to be honest with you. I would rather be on the IFI arm, but if I get the interferon, I'm going to try my best to complete the interferon, because that's it. That's all I have, So I would like, I want to feel good about knowing that I did everything that I could do. Now, so it's a very patient. Now, if this was my mother, or grandmother, perhaps, who might not be able to tolerate the side effects of interferon as well, yeah, I don't really encourage them to go on the study or interferon. So it's a patient-by-patient decision.
And for those with the high-risk stage 3, the BRAF drugs would, as you said, that would create an issue that they would develop a resistance early.
That trial coming down the road. I mean, it's happening right now. And I feel personally, I feel nervous about that trial only because if the resistance is going to occur, are we going to, be creating a problem here and using up all of our armamentarium before we actually need it? I could be wrong, though. I mean, maybe at very low tumor burden levels, the BRAF inhibitor will completely eradicate the disease, and perhaps the immune system can get it under control.
Right.
And so I don't know. I'm worried about that it's not going to work. And if I had a choice, if it were me, I would prefer an immune therapy in the phase 3 than a BRAF inhibitor in a stage 3. But I don't. That's just my hunch rather than any science to back that up.
Well, we don't have a lot of options for stage 3. That's for sure. It's a very difficult position to be in. And regarding the MEK drug, now I've heard that, and we have a lot, of course, a lot of patients that are BRAF negative, but they do have the RAS mutation. And I have heard that then the MEK alone might be a positive thing. And actually, I have a patient who was BRAF negative but had the RAS mutation. It went on the MEK and has done very well. Yeah. So I'm curious about that.
I think that it certainly makes sense, and it certainly has shown. I think there was an ASCO abstract with patients wild type, and I think was with NRAS mutations with the MEK inhibitor. I can't remember off the top of my head, but there certainly were some responses with an NRAS mutation with the MEK inhibitor. The responses were still short-lived, and they weren't, again, a home run. But as far as as a building block, I think it absolutely makes sense if we can. The problem with the NRAS, all RAS mutations are just so hard to inhibit, and no one has really come up with a good way to do this. So what do? We focus on the downstream events of RAS, which MEK is included. And it does seem to work in some patients. So the problem is some tumors are pretty smart. It's saying, okay, if you're going to block me, if you put a traffic jam in front of me at 2 or 3 miles ahead, well, guess what? There's an auxiliary road that I'm going to take and go down there and take that. And some tumors are smarter than others at doing that.
So we need to create stupid tumors.
That's right. Unfortunately, melanoma is one of the smartest tumors, and I think there's been some recent, I saw a nice talk the other day of a guy actually trying to classify smart and stupid tumors in an interesting way by showing the amount of mutations that occur in each one of these tumors. And unfortunately, melanoma has one of the highest amounts of DNA difference between the tumor and the patient's germline DNA? And the answer is it makes sense because, what do we if we expose ourselves to one carcinogen throughout our whole life, I think everybody would agree that the sun is probably the biggest exposure in causing DNA damage. Rather, even if someone smokes 50 packs or a pack a day for 50 years, those people also have a lot of DNA damage, but still not as high as the DNA damage in a melanoma. So, so having that many mutations makes it gives it a lot of opportunities to go down different pathways. Let's put it that way.
Wow. So we do have a large population that can't partake in any of the BRAF therapies. So, and the PDL and the PD-1, I do realize that there's some testing for that biomarker, but when I brought that up to the scientific board, they said pretty much that it doesn't exist yet for patients. Is that true?
Yeah, I would say that's a tricky test to do, to be honest with you. The antibody, and I unfortunately have experience doing this and seen bad results and good results depending on the antibody that you use, and it's not quite standardized yet, although I think we're getting very close to having it standardized. And right now, at least, none of the studies even care what your PDL1 status is to get you on the study. And I think that's appropriate because I don't think we really know. I mean, the slide that I showed about the PDL1 staining was too small to say that with any definitive declaration that we should exclude patients. So not knowing your PD-1 status for now is not a big deal. Now, that might happen in the future where if 0 patients continue to respond with a negative PD-L1 stain, then yeah, I think that might be something that patients are going to have to think about. However, the other issue is, well, I know for a fact that PD-L1 status changes. So a tumor today with no PD-L1, well, guess what happens when you treat it with a BRAF inhibitor? Well, the PD-L1 can go up, actually, or excuse me, go down. It goes away with treatment, and then when it becomes resistant, it goes back up again. So it's not a static thing. That's another thing that's going to be really, this is why as clinicians and investigators, we do encourage patients to do as many biopsies as they think they can do. We hate to put them through that if we don't think it's going to help them, but the tumor does change every single day, and that's I think one of my biases is bringing in immune therapies. I really feel I'm a believer in immune therapies, and one of the main reasons is, if the tumor's changing every day, and the pill that you're taking on Monday is the same pill you're taking on Friday, well, that tumor's getting smarter from Monday to Friday and the next Monday and the next Friday, and the tumor's continuing to evolve, but the pill or the treatment is not. So what kind of treatment also evolves on Monday and changes on Tuesday and changes on Wednesday and Thursday? Well, the only one that I know of right now, although there's more coming down the pike, science fiction right now, is probably the immune system. It continues to adapt as the tumor adapts. Now, the problem is, how are we going to overcome the tumor immune evasion that is currently, that limits immune therapy? But if we can overcome that limitation, then I think you see from those spider plots that once the immune system learns to recognize the tumor, it continues to probably evolve with the tumor. The tumor is probably trying to break free somehow, but the immune system also has DNA capable of changing and becoming something different every day, and is able to keep it in check. But the challenge, so it's not a big deal if we can overcome it. But what about those patients where the immune system just can't overcome it to begin with? And that's where I think, if we could slow the tumor down with immune therapy or targeted therapy or chemo or whatever, so that we can overcome that immune evasion, then the immune system has the best chance to work.
Yeah, and the frustration for that is that PDL and PD-1 are moving rather slowly out there, and access to them is really, really limited. And
Yeah, but it's picking up. It's picking up. You know, there's more competition. Genentech just opened theirs, PDL1. So now we got Genentech, and they're already combining it with Avastin. And you know, so the more competition on the market, the less that these companies, you know, they're going to have to be worried about moving too slow, or else they're going to be beaten by their competitors. So it's getting better. BMS, Merck, Genentech are going to be competing.
GSK. I think
Yeah,
GSK
has a pseudo PD. It's more of a PDL2, I believe, compound. So yeah, this is all good news for the patients.
We need that. We need that a lot. I wonder if the testing won't come with an approval like it did for Zelboraf. You know, they had the test approved along with, or not because of what you say with it changing.
Yeah, I mean, who knows? I personally, I don't know. I don't know what's going to happen. I don't know.
And do you agree with the theory? I haven't seen this scientifically proven, but PD-1 stays in your system for a very long time after you've completed the therapy.
Yeah, the half-life of the drug. I honestly don't know the answer to that. I don't know what the half-life is, but I've treated patients with the drug and have seen some side effects, and I see the side effects go away pretty quickly. So I don't. So it leads me to believe that the half-life is not too bad, or something to worry about.
I know there was a theory that it stayed a long time. So then, if you did another therapy like your VOI, you would, you know, still have the PD-1 in your system.
Oh yeah, that's possible. Yeah, it could be. You could be amplifying your immune system even worse. I think that is something, you know, at least ipilimumab after IL-2 didn't look so bad. Doesn't look more toxic. I've heard that IL-2 after IPI can be more toxic. So I think, yes, sequencing these things we still have a lot to learn about that.
Yeah, that's for sure. And you mentioned that Temodar study. Isn't Temodar the same thing as dacarbazine?
It's similar. I mean, there are definitely the back. You know, one's obviously oral. Temodar is an oral pill. Dacarbazine's IV. Dacarbazine is cleared through the liver and causes a lot more. It has to be converted to a prodrug through the liver, and that causes a lot of the hepatotoxicity, the liver toxicity. In Temodar, you don't see that. You know, Temodar also can cause constipation. If you can cause diarrhea, maybe that helps too with balancing out side effects. Who knows? So yes, the drugs are slightly different, and I wouldn't have expected to see better results with IPI and Temodar than IPI and dacarbazine. And I think the study is way too small to definitively say that that's going to be better. I mean, I'm not going to do that at all. But it was kind of, I thought, it was, you know, interesting. Let's put it that way. And it is something that, you know, the community oncologist could consider doing, you know, without doing it on the trial if they wanted to be more effective, you know. But, you know.
What about combining the BRAF with your VOI, Zelboraf and your VOI? There was some evidence, but it was in mice, I think, by Rebus and Lowe, and they seem to show some benefit from combining those two. Is there?
I think it's very promising, and that study has already been started. And there are, I think, the results from what I hear so far is that the toxicity I heard is a little bit more than what we would have anticipated, I think. So I think they're still trying to figure out the correct way to dose those two drugs together. But once they do, I am optimistic about any of that combination being better than either agent by itself.
Okay. Then my final question was about Alavectin, and that it was in a phase 3 trial, and this person said the results were delayed because of success, he thought, and he just wanted to know if there was any news out there on Alavectin 7.
I personally do not know. I haven't participated in any Alavectin studies, so I don't have any inside scoop on how that's going. So.
Okay.
Yeah.
All right. Well, I think that's all the questions, and I really, really appreciate all of the time you've taken for us today. And this will be, archived for later time, and so many, many patients will benefit from it. And thank you so much for your time.
Absolutely. Thanks for having me. Take care.
Okay. You too. Bye-bye.
Bye.